All right, everybody. I hope you guys got refueled and and you guys can come closer if you want to. Right now, what I'm going to do, this is a panel of really awesome people. I'm going to let them introduce themselves. And I'm going to throw some questions out there, and we're going to also leave it open for you guys to ask questions. Panelists will be sharing the mic. Make sure it's up here, not down here. Okay, so first I'm just going to have each of the panelists tell us a little bit about themselves and what you do. So, Ms. Charlie, I'm going to start with you. Okay.
Hi, my name is Charlie Daniel, and I am the program coordinator for the African American Opiate Coalition. What else you want to know about me? I'm married. I have 3 girls. I have 1 granddaughter. That's it. That's the story of my life.
I'm Sky. You guys met me just a minute ago. I am the Drug Poisoning Prevention Program Manager at Safe Communities, a therapist working with people that struggle with opioid use disorder and complex co-occurring disorders, and a person in recovery. I'm a mom of 2 beautiful children that are the best thing that ever happened to me, and also did not want to wake up this morning. All right.
Hi, I'm CJ Webster. I'm Executive Director of Common Threads down in McFarland and also a licensed marriage and family therapist with Stone Tree Therapy up in Wanakee. I don't have kids, but I have a lovely wife who's
Lovely.
Lovely. Hi, I'm Tanya Craigie. I work also at Safe Communities on the drug overdose prevention team. I'm a program supervisor for that. I am a supervisor for recovery coaches. I also am a person in long-term recovery, a trained mental health and substance use facilitator, as well as I work at Dane County Crisis, working with people who are in crisis for mental health and substance use. We get a lot of those calls lately. I'm also a proud mother of 2 children, 2 and 12, so a very big, big gap and learning differences there, but they keep me on my toes, and I'm a proud member of this community.
So, Tanya, my first question is to you. Can you tell us what a recovery coach is and how successful is the recovery coach program?
So a recovery coach is a person in long-term recovery who is, reached out and said, I want to help others. Currently within our programs at Safe Communities, we pay our recovery coaches for their time so that they feel good about what they're doing. I know that each and every one of them would do it for free because they just really want to help other people get well. So recovery coaches for us are trained for 30 hours, and they go through a certification process, which includes like ethics, boundaries, scenarios that they might run into, self-care. That's a big part of it, taking care of themselves so that they don't necessarily fall back into other things for themselves, and we really work with them on maintaining their own recoveries so that they can continue to show other people how to have recovery. It's not a specific one path that they do. Recovery coaches want to help another person define what recovery looks like for them and then help them on that journey to obtain that recovery, which consists of a lot of different things, faith-based stuff, AA, Narcotics Anonymous, things like that, but it's not always just one thing. Our recovery coaches do many different things for their own recoveries, and they really don't try to tell a person, like, this is what you need to do. They really want to get what that person wants to achieve as far as a quality of life for them, and then help them get there and be that access to service, that resource to get them to those services, and really be a primary support and take their hand and walk with them and say, I know what it's like to have been where you are, and you can do different things. Recovery coaches, right now our recovery coach program started with ED to Recovery, which is a program that if a person came in off an overdose in the emergency room, we were given a call, and then we have an hour to get to the call, the recovery coach, and the recovery coach goes and meets with the person that overdosed, and they help them get into treatment. They have daily contact with them, and they'll meet them for coffee, or they'll meet them at a meeting, or whatever it is, until that person has an affirmed intake at treatment. And then they don't really fall off, even though we're like, oh, you don't necessarily have to work with them anymore. They just won't do that. I mean, they now have this connection with a person, and they're not going to be like, well, I'm not getting paid anymore to have a relationship with you, so it's over with. They really still check in with these individuals and develop a relationship because they feel that connection from that acute setting to continue on their journey of recovery. That program has had a close to a 90% success rate. It's like 89.7 in getting people into treatment, so we rounded up to 90. And so with the success of that program, we've taken, we had this Women in Opioids group that would meet and talk about the needs for women, the needs for pregnant women in our community and what that looked like, and the need for getting women connected with resources if they were pregnant, getting on medication-assisted treatment, things like that. And we're like, oh, we could take this recovery coach model and utilize that and push it out into these other women that are struggling with opiate use disorder while they're pregnant, to get them stable, to help them feel like they can be mothers. And the coaches within that program, they're in recovery, and they also had substance use while they were pregnant, so they know what it was like to go through that shame, that guilt, that embarrassment, and now they have sustainable recovery. They have strong bonds and relationships with their children, and they're able to model for these other women that it's possible and that they can be really good, competent mothers and have relationships with their children. And now, I don't know if I should share too much about this because we haven't really gone public with it, but we're now going to be working with individuals in the jail as well and getting them connected with recovery coaches and getting them on Vivitrol and then supporting them in that process, going to the support groups that they attend, and we're really excited about that too. There's a ton of possibilities for recovery coaches. Peer support has proven to be effective, and I think that's because there's not this power dynamic. I can do a lot as a therapist, but I think I can do more as a person in recovery sometimes, and not having that, I know this, I read it in a textbook, or I had some training, and so you should listen to me. It's really being like, no, I've been through this, trust me, and if you do it, it might work, and trying different things, that's important. But peer support is different than a mentor. It's different than a sponsor. They might still give you, some assignments or whatever if they ask for it. But it's really a person just to walk on your journey and validate the pain that you've been through and also that need for change.
Okay, CJ, you're up. What is family systems therapy, and why is it important in this epidemic?
Just a small question. Sorry, what was that? Just a teeny tiny question, yeah. Family systems therapy. Let me start with what it's not, but lots of people think. Family systems therapy isn't simply having everyone in the room. That can be useful, but simply having all the family there is not quite what we refer to when we talk about family systems. It's also not an excuse to blame the family for what's going on, which is the fear that people often have in turning up to family systems. What it is it's a multidisciplinary approach that looks at biology, looks at the person's affect, looks at their cognition styles, looks at their emotional styles, and most notably looks at the psychological ecosystem of how people interact to help bring about therapeutic change, using more than just the one person, but looking at different elements that you have access to. So in our world, at least the way that we like to talk about things in the media, in research, we like simple answers. We like A plus B equals C. That's not how the real world works. In reality, A plus B equals C if D and E are also present, but it equals G if B is tired and F is lonely. That's reality. That's how it really works. And so family systems therapy essentially analyzes all those structures and codifies that in a way that I can then use that knowledge and that research to evoke change in different ways rather than just individually one-on-one. It's not always a whole family in the room. Sometimes I'm working with just the parents, while someone else is having therapy in a different sense. Sometimes it involves everyone in the room, grandparents, parents, siblings. It all depends on the structure and the technique I'm using at that stage. Why is it important? When you have access to all those different avenues to evoke change, you want to use them. And so not to have access and not to use that is really to limit your resources in a couple of ways. One, if some of those interactional patterns are making recovery more difficult and you haven't addressed it, you make that work harder. Also, you have access to resources that are beyond the individual, the support groups, the other people. And so leveraging that for maximum change is effective. It's also really important because research backs it up. Where we have more access to actually making change, you get better results. And so if you're going to be getting better results and the research backs this up, we should be doing it. That's why it's important. I know it's a basic concept, but we don't always follow these rules in how we deliver. It's also really important for change because we sometimes think as a society about what we would call in my field of systemic therapy about the identified patient, the person going through addiction. And we're not actually thinking about what effect is that having on the family. What about the siblings? Are they dealing with mental illness at the same time, from depression, from anxiety? And how do we support them? Because in some situations, the effect it's having on the rest of the family becomes this cyclical nature. Not all the time, but sometimes. And so if you only treat one part of what we refer to as the ecosystem, then other parts are allowing this to continue and making it difficult in different areas. So as a systemic therapist, I try and look at that holistic picture and move different portions, and that's why it's important as well.
Awesome. Might as well just pass it down to Scott. I'll talk really loud. So what are siloed services that... All right. All right, so what are siloed services? That's a term that is frequently heard in the industry, and I don't think people understand what siloed services are and why they're really kind of stink. And then why are we moving towards an integrated therapy type model?
So stink is a very technical term. So siloed services are where you're not looking at the whole person, right? You know, an example of this is I had a client who had a significant eating disorder, right? So she was very low weight. She suffered from anorexia. She also was using substances and had a substance use disorder. And then she had a bipolar diagnosis and a PTSD diagnosis, right? This woman clearly needed a higher level of care. Outpatient with me was not enough, right? Her life was at risk. I needed to get her to an appropriate level of care. When I called places to have her substance use disorder treated, they said that they could not take her because she was active in her eating disorder. When I called eating disorder programs in order to be able to get her access to those places told me that they would not take her because she had not been sober for 30 days. Having a program that meets the needs of the people that it serves, as opposed to having a program that is set in stone and that the person needs to change in order to fit with the program, is not acceptable. It limits people's access to the help that they need. I am certainly not advocating for staff that are not trained and it is out of their scope of practice to practice in ways that they should not. I am very much advocating for treatment programs to develop comprehensive staff and services so that we can treat the individual and reduce those barriers to service.
All right, Charlie, why did you form the AAOC? Also share what that stands for. And why is it important to have this perspective at the table?
Because Cheryl told me to form it, that's why. The African American Opiate Coalition is what the AAOC stands for. And Cheryl, I always joke, she never wants me to say this, but she's the reason that we are a project of safe communities. But it started, we're going into our second year, and I was just thinking about that the other day. And as you can see, I'm the only one with notes, right? All these young people could, on top of their head, I'm the only one with glasses,
Wait a minute here, I have notes, I have glasses.
So I'm going to try to do this with the notes. When you get to be my age, you have to write everything down. So, that's okay. But anyway, the reason the AAOC was formed is because we don't want to be the last people at the table. And I always say, if you're not at the table, then you're on the menu, right? And as African Americans, I don't want us to go through what we went through in the 80s and the 90s with HIV/AIDS. We saw it as what? A white, gay, male disease, and who now has the HIV, heterosexual African American women. So we don't want that to happen again now in 2018. So the AAOC was formed in order to do education and outreach and have African Americans come to the table to be ambassadors to the African American community. And we've done a really, really good job of that in the last year that we've been formed. We've been able to go out into the communities that we serve, and we come from all walks of life. Right now we have about 35 members of the AAOC, and every day somebody's calling, we want to become members. I want to cut it off, but Cheryl said, hey, keep going, keep going, keep going. And so we're going to keep going, keep going, keep going, which we're very happy that we can have people that are very interested in becoming involved with the AAOC. I think it's very important as an African-American woman to be able to go out and educate, because I have a granddaughter, and she talks about teenagers coming, she's in 9th grade, and she talks about this one guy, his name is Junior, who she started kindergarten with, and now they're in 9th grade together, but now Junior is smoking marijuana. Well, they don't say marijuana. They say weed. She told me, she said weed. Junior is not smoking weed, and it's very disturbing to her that Junior smokes weed, and she doesn't know what to do about it, but she sees other kids at her high school that are smoking weed, and I don't want her to smoke weed. I smoked weed. I always have to tell this story. I'm a flower girl. I smoked weed in college in the 60s, and I truly enjoyed it. I ain't gonna tell you no lie. That's another story. I have to tell you why I stopped, but I don't even want to go into that one, but anyway. But what we're finding out is that African Americans are at risk for being the number one again. We number one in so many other diseases, and this is a disease. And this is what I do when I do my presentations. I talk about the epidemic being a disease, and it is a disease in the African American community. And what I need to let people know in my community know is that there are services out there for you. We got to talk about prevention, and we got to talk about prevention early. Not when you in your 20s and your 30s, but we need to talk about it in middle school. And you know what? They're going to probably start talking about it in elementary, because this is how rapid that this epidemic is growing in the communities that we serve. So my job now is to really to educate, to outreach, and really to talk about prevention. Let's get them early, and that's what I'm hoping that we can do in the African American community, and not only in the African American community, but in all communities. I am culturally Pacific. My grant is culturally Pacific, so when I talk, I am going to be talking about African Americans, but I want you to know that we are inclusive. We all in this fight together. What was the other part?
The other part was, why is it important to have your perspective at the table as an African American woman?
Because we're going to be on the menu if we don't. it's important that our voices are at the table, and our voices are different than other voices, and we know that, and you know that. I come from an entirely different background than most of you. I'm a Southerner, you know, I come from Mississippi, and the training and the way I was raised is much different than probably the way Richard was raised as a Northerner. And, you know, don't lump us all together. We Southerners, we have a different mindset than you Northern folks. But it's very important that we are at the table and that our voices are heard.
Thank you. All right, if you want to pass it down to Tanya. How do you match recovery coaches to clients?
Well, currently in all of our programs, we like them to have that shared experience. With the overdose program, it's now expanded. So it initially started off with working with individuals that come in the ED off of an overdose. Now we can serve anyone that comes into the emergency department and is seen for anything, like if they're suicidal, if they're pregnant, and they identify as having opiate use disorder, we can now connect them with the recovery coach. The recovery coaches within that program have opiate use disorder, they're in recovery from that, and they know what it's like to have overdosed. And so not every other region in Wisconsin that's doing the ED to recovery program has that requirement. At Safe Communities, we feel that that's really essential, you know, to be able to talk to these people that have the overdose, to be able to say, like, I've been there, this is scary, this is a shared situation. Same thing with the jail to recovery. We like to recruit individuals that have had that experience of being in jail and know what it's like to come back in and have that reentry piece and be a person in recovery and not have their needs addressed while they're incarcerated, in addition to the pregnancy to recovery program. The women working within the pregnancy to recovery program right now may not have opiate use disorder specifically because we really focus on the shared feelings that they have. They did use substances in pregnancy. They knew what it was like working with the doctors and not being viewed as a person. Having that shame, that guilt, that embarrassment, not having that self-efficacy, and really building on that and feeling empowered to now talk to professionals and feel more as an equal. And so it's not that they necessarily have opiate use disorder, but they do have that shared experience of having used during their pregnancy.
Thank you. All right, CJ, just hang on to it. Can you talk a little bit about the current studies related to anxiety in our youth?
Yes. So if we look at anxiety with youth across the nation, so the DSM Diagnostic Statistical Manual talks about anxiety in youth being at about 1% and for adults being at 3%. If you look at recent studies done in Dane County, for example, in 2012, they didn't ask exactly, do you have anxiety disorder, but they asked enough strategies to say that it mimics pretty much what we would call that. For Dane County in 2012, around adolescence, we were looking at something like, I've got my statistic, 18.5%. Which is drastically higher than an average. When we get to 2015, we're looking at closer to 25%. And we haven't got the 2018 results yet, because it's only done every 3 years. So we're seeing not only, at least in our area, an increase in anxiety, or the symptoms that we would link with that sort of situation, but we're also seeing that it's growing. It's not only higher, it's markedly growing in the amount that we're seeing, particularly in adolescents. When we look at that, the reason why it's really hard to research often is that people write it off as part of adolescence. You know, you are depressed in adolescence, you're anxious in adolescence, so there's nothing really wrong. And so by the time it takes us to actually get there to research it or to get help, it gets to that really desperate age where you are intervening at a much higher rate. Whereas if we'd actually caught it earlier, which is the talk of therapists all the time, if I could have seen you 2 years ago, it would have been different. And maybe it would, and maybe it wouldn't, but where we are now is that we know that change is happening, and we know that this is affecting our youth. And so we can't simply sit by and say, well, maybe this is part of adolescence. We have to be proactive and we have to change. And we know strategies to work with all these sorts of things. So it's not like we don't know what to do. It's just a matter of having the desire to notice it when it happens and then act on it and not be afraid to ask what's happening and to offer advice and to model that for ourselves as adults, for adolescents. If we're going to therapy, if we're getting the help when we need it, if we're modeling that we do get anxious and we have strategies that work that's going to be different for our kids as well. And that's just what we've got to work on. But it is changing and it is increasing.
Thank you. So Sky, how did we get here with this huge opiate mess?
That is a great question. So there was a number of things that happened that created kind of a perfect storm in our country. So one of the things that happened was that there was a movement within the disabled population that really asked for better pain management, right? This is a positive thing, right? People that were struggling every day with chronic pain asked to be treated and taken seriously by their doctors. This resulted in pain becoming the fifth vital sign, and prescribers then got rated on how well they managed their patients' pain. At the same time, pharmaceutical companies were coming out with different formulations of long-acting opioids. When this occurred, there was like an opinion piece that was published in a newspaper that said that when opioids are used for pain, they are not addictive. This was an opinion. It was not research. It was not studied. It was not peer-reviewed. The pharmaceutical companies used this opinion piece in their marketing and went into doctors' offices all around our country and told these doctors that these medications were not dangerous, that they were not addictive as long as their patients had pain. Doctors, the vast majority of doctors are really great people and are trying to help their patients, right? So when a patient came in with pain, the doctor then, with this new wonderful information that there's these new formulations of long-acting opioids that aren't going to be abused and don't have risk for addiction, of course, they're going to prescribe these opioids, right? They see that person in front of them in pain. They see that person struggling. So the doctors prescribed these opioid medications. What happened is that the number of opioid prescriptions in our country rose incredibly dramatically over the next 15 years. Then we started to see that the numbers of people using heroin also started to rise about 5 to 7 years into that dramatic rise in opioid prescriptions. Now, synthetic opioids, which are illegal opioids that are made through labs, are now, they're just starting to take off in the last 3 years. The Midwest is being hit the hardest right now. We have more people dying from synthetic opioids in the Midwest than in any other part of the country. Wisconsin is being hit particularly hard. I want you to understand some of the social dynamics that come into play here. I was using heroin when I was in high school, and I did not tell anybody, right? The people that I used with knew this, but this was not something that my high school knew because it was not socially acceptable to use heroin in high school. When doctors started to overprescribe these opioid medications, what was socially acceptable in high school is, maybe you drink a couple beers, maybe you smoke a little weed, maybe you take a couple pills. They came from a doctor, they're safe, right? it started to become socially acceptable in high school to use opioids. And that was the first time in the history of our country that that had happened. That meant early initiation of use. Opioids, the street value for an opioid is $1 to 1 milligram, right? So buying an 80 milligram Oxycontin cost you $80. That was before they changed the formulation. Now, anybody that's using them will tell you they're not very good, and I think that the price has gone down. But before that, $1 for each milligram, right? When people would run out of money and they would start going through opioid withdrawal, people became desperate, and then they switched to heroin. Heroin was cheap, it gets them out of opioid withdrawal, and then all of a sudden, all around our country, all around our state, all around our county, all around our communities, we had teenagers that were shooting heroin. That hadn't happened before, and we really do have to think of those social dynamics, why that became socially acceptable in high school when it never had been before. When we're thinking about what's acceptable for teenagers and how to change that thinking, that is prevention, right? So getting the message out that just because it's prescribed by a doctor does not mean it's safe is a very strong prevention message. Because we have gotten that message out pretty effectively, the latest National Household Survey of Drug Use shows the lowest level of prescription opioid initiation in teenagers since they started studying that dynamic. So the prevention message is working, yay. Less people are starting opioid addiction, yay. The people that have an opioid addiction that are still struggling with their addiction because it is a chronic disease, and when this perfect storm occurred, a lot of people started a chronic brain disease of addiction at that time, are so high risk for death because of the synthetic opioids that are out there right now. As a person in the recovery community, we are terrified. We are losing so many people, and it is hard on your heart when you get the next notification that somebody else has passed away. So in some ways, we're doing a really great job, and in other ways, there is so much work left to do.
Thank you. So Charlie, what are some of the areas that all of us could help in bridging the gaps with the African American community in this?
Well, first of all, awareness. As you can see, the media plays a really big role in this epidemic. And what do you see? What does the media do? They show, I feel sorry for any blonde right now. They show this young blonde woman that's ODing, sitting in her car with her babies. They show rural America, right? They show the upper middle class kids in suburbia, but you never see them showing anything about inner city kids, African Americans, or middle class, whatever class they are. You never see them showing any type of people of color using this this drug and being involved in the movement. They never show that. So I feel as though the media has a big role in this, and that's what we need to reach. And we now have a person from the media on the AAOC coalition who will be bringing this to the forefront. In fact, the editor of The Hue was just here, and he was saying that he wants to really do a big article on the epidemic in the African American community. And people of color are always the last. We last on everything that comes, but we're the first when it comes to all these dreaded diseases. And, I was thinking about, too, my Native American sisters and brothers. You never hear anything about Native Americans in this epidemic. And the CDC came out with a report in 2014 where there are more Native Americans dying of opiate deaths than any group. But you don't hear about that, right? Nobody talks about the Native American and their plight with this disease. So I think awareness, we need to do an awareness piece, and that's what we're really good about doing at Safe Communities, because we're in these various communities and we're getting the word out. So I'm very happy. You know, it's really, my background is in education. I worked for the Tech College for a number of years. So the work that I did had nothing compares with the work that I'm doing today. I really feel fortunate to be able to be involved in this movement, but I'm sad about that I'm involved in this movement, because this is not a movement that I want anybody to be involved in. But if somebody got to do it might as well be me, you know. I always say I'm a rebel with many causes, and this is one of the causes that I'm involved in right now. So it's my job to bring awareness to not only the African American community, but communities of color as a whole, and that's what I want to do.
Thank you.
You're welcome.
All right, so I'm just going to pose a question to all of you guys, and then I'm going to take questions from out here. What is one thing each of you would like to know about what you do and the people you work with?
You want to start, Charlie?
No.
Start Charlie.
You're up, Tanya.
Could you repeat the question, please?
What do you want people to know about as a person in recovery and the people you work with and the people suffering from mental health illnesses? What is something you really want people to know about them?
Oh, man. The thing that I probably say the most is that we're humans, right? Like, we're all humans. And I think that when we get caught up in the cynicism and the judgment and the comparison, that we forget that this is somebody's child, this is somebody's sister, this is somebody's father. We forget who they are on a humanistic level. And I think at our core, we're all good. We just have a lot of bad things happen to us, and we don't always have the skills to get through those bad things. And so we take what we perceive to be the easier, softer way, which really is the most traumatic way. And we forget that these are people. And so that would always be my thing, is to bring it back to this is a person, and they deserve respect and dignity and care and love.
Probably say the same thing with different words, but I think a lot of the time, especially with working with families, I would want people to know that it wasn't a failure. Like, you didn't necessarily do anything wrong. You didn't make this happen. It's not because you raised your child wrong or something like that. These things happen, and dynamics are important and can help contribute to finding solutions. But this happens to families all the time from all sorts of different situations, and that doesn't reflect on who you are as a family, good or bad, in that sort of sense. And I'd also echo everyone I see for all sorts of issues, they're trying to solve them the best they can. Everyone has the best intentions, no matter what, whether it's dealing with their depression, their anxiety, their trauma, all these things that they're working through, they're doing the best they can with the resources that they have. And those resources may not be working and may not be solving the problem, but that's their main aim. They don't want to be in the pain or the hurt or the feeling where they're at the moment. And so everyone is actually trying their best in any given situation. They might just need some extra from someone else.
I might get a little teary answering this question.
Sorry.
So, I think that, so I work with a number of different types of people. And what I'll speak to is what's the most meaningful to me. So many people that are affected by the disease of addiction, whether or not it's their own personal struggle or the struggle of a loved one. When those people trust you enough to tell you their story, right? And you know, I have the great honor of hearing those stories, and I think to myself all the time, like, how are you even here right now, right? How did you decide to keep trying? How did you find it within yourself to trust a human being after what has happened to you? You know, how did you decide to keep living when life was so incredibly painful? How did you hold on to the most beautiful part of your humanity when you were never treated with kindness, right? And I truly believe that I get to witness the most beautiful part of humanity in those moments. You know, the people that I work with inspire me every day.
Thank you.
Well, I think you should always think of other folks as your brothers and sisters, regardless to what race they are or what gender. They are your brothers and sisters. Nobody wakes up in the morning at, well, I'll just give an age, 21, and say, hey, I want to be addicted to heroin for the rest of my life. Nobody wakes up with that mentality or that thinking that. I always think of compassion. You have to be compassionate with folks. You have to think of people walking in their shoes. You know, what happened to them that made them get up that morning and decide to start using? It has to be something, some type of trauma that happened to them, and you have to put yourself in their place and be more understanding of what they are going through, I think. We're so apt to oppress people and think we're better than, you know, that's the way this society is. But to me, all people are my brothers. I'm the only child, so I got lots of brothers and sisters. But I think of people as being my brothers. This is my brother. This is my sister that's going through this. And any way that I can help, I'm there lending a helping hand.